Hello YouTube, my name is Stefan Harmon, PA, Exercise Science Specialist and Health Coach at ironmedicinepa.com. Welcome and joining me to the lecture on essential hypertension, best practice. Let's hop right into it. Epidemiology, the WHO has identified high blood pressure as one of the most important modifiable risk factors to reduce the rapidly escalating burden of cardiovascular disease globally. This lecture is going to be a two-part. The first is how we currently treat medicine, or how we currently treat blood pressure medicine through pharmacology. And that's going to go over the best evidence we have pharmaceutical-wise to treat blood pressure. The second, I'm going to introduce the new theories and hypotheses as to what is driving high blood pressure and what we can do lifestyle-wise about it. So here we have the stages of high blood pressure. We can say anything less than 120 millimeters of mercury systolic-wise is normal. Anything less than 80 diastolic blood pressure is also normal. And then we start going above those, we start seeing elevated blood pressure readings according to many different guidelines. These are considered high blood pressure in various stages. The pharmaceutical treatment, interestingly enough, is often ethnicity-based and disease-based. When we have a black patient, a stage 1 hypertensive, say a systolic of 140 to 159, and a diastolic of around 90 to 99, we give the patient a calcium channel blocker and a thiazide diuretic. If still high after 2 weeks, we add on an ACE or an ARB, or combine a calcium channel blocker plus a thiazide. However, one important thing to note is that ACE inhibitors have the risk of causing angioedema at increased rates in black patients. And angioedema is, as you can see in that picture, it's a swelling of the oral pharynx, and this can lead to rapid death if epinephrine and emergency treatment is not given. We never like to give two medications at once because, as you can see in this picture, we won't know which one caused angioedema. Now, any drug can cause an anaphylactic reaction. It's just specific towards black patients that are more at risk for ACE inhibitor angioedema and death. An overweight patient is to improve their lifestyle, but we also put the patient on a medicine at first, especially if they're in these stage 2, 3, and beyond. We want to start treatment first with medication. JNC7 was an analysis at the literature. They saw that beta blockers must be given first line to white patients. That decreased high blood pressure, that increased heart attacks and strokes by 30%. So an interesting tidbit there. Diuretics. So hydrochlorothiazide is one of the most common diuretics. Increased sodium and water excretion is associated with this. It's not effective in patients with a creatinine clearance less than 50 milliliters a minute, so that's renal disease. In elderly, who have a decreased sense of thirst, hydrochlorothiazide can be a problem because it makes you pee a lot, right? So if patients don't want to be peeing all the time or are prone to dehydration, these diuretics are probably not the best idea. Now, hydrochlorothiazide can also cause hyperglycemia, so high blood sugars in about 10% of patients, and it will cause hypokalemia, so low potassium. And very low potassium is pretty significant heart. It can cause some problems with the heart. Right? You can even see death from the heart. Mortality. What was that last part there? Let's see, statins. Statins also increase the risk of hyperglycemia, so that is also very interesting. Sometimes we treat one thing and we may be causing another disease. Lasix is another diuretic. It causes a lot of urination, calcium loss, increase in sugar. It's not the best choice for managing essential hypertension. but it is used often to help get rid of excess fluid buildup in the legs. Beta blockers. So as we mentioned before, we're going to talk about beta blockers here. Beta blockers are beneficial to those in heart failure, and they're easy to start since no labs are needed to monitor these as compared to with the ACE inhibitors and the other ones that cause electrolyte wasting. We don't really need to be monitoring these so much. But they do slow the heart rate, so beta blockers do slow the heart rate. Propranolol, we want to be aware of this one. We shouldn't be using this in people with chronic lung disease, so asthma and COPD. Metoprolol would be a better choice. You don't want to give a beta blocker for acute heart failure. I know it is used to treat heart failure, but not in acute heart failure. Beta blockers are useful in hypertensive symptoms such as migraine headache, angina pectoris, such as chest pain, supraventricular tachycardia, previous MIs, and congestive heart failure, causes bradycardia. Abrupt beta blocker cessation may cause withdrawal symptoms. And patients may induce angina, myocardial infarction, sudden death in patients with ischemic heart disease. You would like to taper it over 2 to 3 weeks. ACE and ARBs, we'll go over these a little bit more. The ACE inhibitor cough, pretty common. About 2% of patients would develop a dry, pesky cough from an ACE inhibitor. So something important to note if your patient is coughing and you don't know why. ACE inhibitors reduce peripheral vascular resistance. So think about what will happen if your heart rate doesn't increase, you will pass out. So that's a risk with all these blood pressure medications, is passing out. But these ACE inhibitors especially. ACE inhibitors have been shown to stop the progression of kidney disease in diabetics, but it can also cause a slight decrease in kidney function. So yeah, this is actually kind of interesting. You'll put a patient on an ACE inhibitor and you might see a decrease in their GFR. But a lot of practitioners will consider this tolerable in the diabetic because the studies have shown that it decreases the rate of kidney failure overall, or decreases the progression of kidney failure overall. Side effects of the ACE inhibitors: hyperkalemia. So the opposite of the diuretics, it can increase potassium, and an increase in potassium can also cause heart death. So something we need to monitor. We use the ACE inhibitor in those with diabetes, high blood pressure, who are white and who are young. If borderline high potassium, you don't give an ACE inhibitor, of course. And yes, the angioedema risk with these ACE inhibitors. ACE inhibitor helps patients with diabetic nephropathy because it lowers the pressure inside the kidney. This is a tidbit I learned in PA school from a nephrologist. Let's see, okay. Other ACE inhibitor contraindications: pregnancy, that can cause fetal death, hyperkalemia, as we mentioned. Both ACE inhibitors and angiotensin blockers protect the renal symptoms, protect patients with who could progress to CKD. Calcium channel blockers, yes, we have to talk about these. You're seeing here a picture of pitting edema. So if you see someone with swollen legs, there's going to be a lot of reasons for that, but an easy one to knock out of the ballpark and impress your preceptors with is if the patient was recently put on a calcium channel blocker and then developed pitting edema in their legs for no apparent reason. You can impress anyone who you're rotating with in your clinical education by pointing out the calcium channel blocker. Let's see. Very effective in angina, which is chest pain, or diabetes. There's no lab monitoring that's needed with these. They dilate the blood vessels, so this affects the cardiac and smooth muscle. Amlodipine is one of the most common drugs. Alright, let's talk about the alpha blockers next. So alpha blockers are used for multiple different reasons. I've seen them even used in psychiatry sometimes. Alpha blockers can cause postural hypertension. So you have an elderly gentleman who's laying in bed at night, and he has a large prostate. So he gets up at night to go pee, and he falls down and ends up in the ER with a cracked face. This is kind of common. This is called orthostatic hypotension. And when you put someone on an alpha blocker, and they're probably on other medications as well, and the more medications, there's a lot of medications that can cause orthostatic hypotension, but the more that you are on, the increased risk of falls. So, the alpha blockers are used in prostate disorders, but they can also be used to treat high blood pressure. Sometimes you can hit two birds with one stone. If you have an elderly gentleman, large prostate, has high blood pressure, boom, you can treat both things with one. Great. Disease-based treatment in summary. So we can look at the diabetes mellitus. We know we need to put the patient on the ACE and the ARB to slow the progression of renal disease. And if that's not enough to control it, the high blood pressure, we add on a thiazide or a calcium channel blocker or a beta blocker. Chronic kidney disease, we use the ACE and the ARB. Coronary artery disease, we use the beta blocker, the ACE, or the ARB. Heart failure with reduced ejection fraction, we use the ACE, the ARB, and the beta blockers after management of volume overload, so you never add these, add them in acute heart failure. Alright, and then heart failure with preserved ejection fraction. Pretty much similar management there. Now we're going to go to part 2 of this lecture. So, mainstream theory of hypertension, and we can see a nice Time magazine article there, and I've gone over how we got to the whole theory that salt and cholesterol causes diseases before. We're going to go into it a bit further here. So mainstream causes of hypertension are a diet high in salt, fat, and cholesterol. We're going to go into why that may not be true. Chronic conditions, yeah, we can agree about that. A family history, yes, but your genetics do not determine your fate. Lack of physical activity, oh yes, definitely. Older age, potentially, but many times elderly will have low blood pressure and are at increased risk of falls because of this. And being overweight or obese, yes. Race, so non-Hispanic black are more likely to have high blood pressure than people of other races. This is just a fact. Some birth control medicines and other medicines can increase blood pressure. Stress and tobacco and alcohol. Yeah, those are two big ones. If you're on tobacco and alcohol and high blood pressure, you need to cut those out. I've seen how powerful cessation of tobacco and alcohol has been in reversing blood pressure problems completely. So, let's look at the low salt diet recommendations to reduce blood pressure and prevent cardiovascular mortality, as these have been quite misguided. We can look at some new studies here. One recent cohort study showed that salt intake below 6 grams per day is associated with increased mortality. So they looked at 6,000 patients in about 90 different trials. The author's conclusion: in white participants, sodium reduction in accordance with public health recommendations resulted in a mean arterial pressure decrease of about 0.4 millimeters of mercury. So you have a patient with a blood pressure of 150 over 90. You tell them to reduce their salt intake. You're going to reduce their blood pressure to 149.6. Is that significant? No. We can see that there may be a little bit stronger effectiveness in black and Asian participants, but it's not that very significant either. So, let's see, what else did they show here? Summary: there's no definite proof that sodium restriction reduces cardiovascular events or deaths. It's time for the dietary guidelines to look at the totality of evidence. So, what are we doing here? Why are we continuing to recommend low salt diets to reverse hypertension? One of the theories that I have you're going to see towards the end why I believe this came to be. So, a new theory of hypertension. So, inflammation driving high blood pressure. And what causes inflammation? Well, refined carbohydrate, gluten, sugar, alcohol, stress, poor sleep, low vitamin D, high polyunsaturated fatty acids. So, canola oil, sunflower oil, your margarines, cotton seeds, you name it. These are driving inflammation. Now, when you eat processed food, it has a lot of these ingredients in there. What does processed food also have? High salt. So, you cut out the high salt, right? And you might be also cutting out some of your processed foods. So that might be why we saw in some of these epidemiological studies that lowering salt reduces blood pressure. It's probably, you're kind of getting out a lot of the processed stuff, a lot of this processed carbohydrate, sugar and so forth, and polyunsaturated fatty acids, and that's bringing down the blood pressure more than just the salt restriction itself. And also you have to take into consideration how carbohydrate brings water, helps retain water. So if you're reducing your carbohydrate intake, you're going to be also reducing the amount of sodium you're consuming, and you're going to be less able to hold salt in you if you're consuming less carbohydrate. So it is very complex rather than just lowering salt. Let's look at the study by Dr. D. Nicolantonio. He's been doing some great stuff in the fight against misinformation on nutrition and disease. So he promotes the concept of the wrong white crystals, not salt, but sugar, as etiological in hypertension and cardiometabolic disease. So while the potential benefits of sodium reduction strategies are debatable, one fact about which there is little debate is that the predominant sources of sodium in the diet are industrial processed foods. So processed foods also happen to be generally high in added sugars, the consumption of which might be more strongly and directly associated with hypertension and cardiometabolic risk. Evidence from epidemiological studies and experimental trials in humans and animals suggests that added sugars, particularly fructose, may increase blood pressure and blood pressure variability, increase heart rate, myocardial oxygen demand, and contribute to inflammation, insulin resistance, and broader metabolic dysfunction. Thus, while there is no argument that recommendations to reduce consumption of processed foods are highly appropriate and advisable, the arguments in this review are that the benefits of such recommendations might have less to do with sodium, minimally related to blood pressure, and perhaps even inversely related to cardiovascular risk, and more to do with highly refined carbohydrates. It is time for guideline committees to shift focus away from salts and focus greater attention to the likely more consequential food additive, sugar. So thank you, Dr. Nicolantonio, for putting out new theories that can help aid us toward better decision making. Let's look at interventional trial to lower blood pressure with a low-carb diet. Okay, so the CCI group, which was a health coaching patients on a ketogenic diet group, consisted of 262 participants. Their ages were about 54 and a BMI of 40. So these are heavier set individuals. The 10-year ASCVD risk score decreased by 11.9% in this group. Antihypertensive medication use was discontinued in 11.4% of this group. The usual care group, so the American Diabetes Association guidelines, your standard low salt, low fat, there were 87 participants showed no significant changes. After adjusting for baseline difference when comparing the CCI and the usual care group, significant improvements for the CCI group included small LDL particle, ApoA1, triglyceride, and the HDL-C ratio, HDL-C, HCRP, and LP1R score, in addition to other biomarkers that were previously reported. The CCI group showed a greater rise in LDL-C. So what does this all mean? If you've looked at my previous videos on the cardio IQ, advanced lipid fractionation interpretation, we understand that cholesterol is more complex and more complicated than a simple LDL and HDL lab panel. We want to look at the size of the lipids, we want to look at inflammatory markers, we want to look at ApoB lipoprotein, ApoA, LPA little 2. And so they found improvements in the advanced lipid panel. But when you just looked at the standard lipid panel, you would see a little bit of a rise in LDL. Now, if you have the old cholesterol hypothesis in your mind, you're like, LDL went up, that's bad. Oof, we have to stop that, right? But if we have a more complex understanding of how disease progresses, how cardiovascular disease occurs, then we understand that this is actually a good sign, right? So, conclusions. This is very small. The reduction of blood pressure with concurrent reduction in antihypertensive medication was also significant. Strong evidence exists that elevated blood pressure is a primary cardiovascular risk factor, and an analysis of large type 2 diabetes populations suggests that antihypertensive medication may have limited effectiveness in reducing the prevalence of hypertension in these patients, whereas a study of weight loss interventions showed that a decrease in blood pressure predicted regression of carotid vessel wall volume. Thus, additional lifestyle interventions that can augment blood pressure reductions, such as the control group as described here, may reduce cardiovascular disease events. Additionally, the antihypertensives that were primarily decreased in this study were shown to increase the risk of diabetes. The removal may represent further metabolic benefit. Now, as we discussed earlier in the pharmacology part of this lecture, we saw that many of these hypertension drugs and sometimes cholesterol drugs can actually cause elevated blood sugar readings, and we know we don't want this in diabetics. And who are we primarily treating with hypertension? We're treating diabetics. So very important stuff here. Now we're going to move on to my own interventions. This is a blood pressure log of a real life patient that I took care of. It was a middle-aged Asian female with hypertension. She sat in my office. She says, "Yeah, I know I need to see you. I've had high blood pressure for a while, but I don't want to start on a medication just yet." And her blood pressure readings were quite high in the office. She was about 150 over 95, and she says at home it was high. So I was kind of concerned about this. I said, "Okay, we don't need to start you on a medication. I want you to try something a bit unconventional. I want you to try an animal-based, nose-to-tail, essentially a carnivore diet. Eliminate all processed foods, no these processed carbohydrates, really no carbohydrates at all. You can have a little bit of berries here and there, maybe a bit of honey, no alcohol." She didn't smoke. And I said, get rid of the seed oils, no canola oils, cottonseed oils. You can't eat out, because every time you eat out, you're going to be getting that stuff. And she monitored her blood pressure. And we can see how it decreased rather rapidly over a couple days. We were getting down to the low 108 systolics, which was very interesting. We would not even expect this with one diabetic medication to see such a huge drop. We would see maybe at a higher dose, maybe a lisinopril 20-30 milligrams, we would see a drop like this. But with no medication to see a drop like this, we would not expect this. Even like a low salt diet intervention, we would expect a drop of 0.4. But to see a drop from 145 to over 90 to 108 over 80 is unheard of. and under no guideline. Let's see here. Yes, so we can see at the couple of visits that I saw her at, I saw her on 4/16/21 and then on 4/30, so about less than 2 weeks. She went from a hypertensive reading in the office to a non-hypertensive reading, and then further in the next month, she dropped to well below high blood pressure, 110, and her diastolic came down all the way from 86 to 68. So absolutely amazing. Hats off to this patient for following through with this unconventional approach. Her weight also coming down without counting calories, came down from 168 to 162. No counting calories done with it, no calorie in, calorie out tracking, right? Just animal-based diet. BMI coming down as well. So good job to her. Alright, so another theory as to why low-carb diets are so effective was offered by researchers of a real-world study of patients placed on a low-carbohydrate, high-fat diet in a general practitioner office and followed about 2 years. So this study was called Substantial and Sustained Improvements in Blood Pressure, Weight, and Lipid Profiles from a Carbohydrate-Restricted Diet, an observational study of insulin-resistant patients' primary care. So these are diabetic patients. So as mentioned in the introduction, a low-carb diet may improve both hyperinsulinemia and insulin resistance, promoting the loss of sodium in urine, so improving blood pressure. So they also kind of believe the old world thinking that high sodium causes high blood pressure, and let's not debate the subject. The point is that they found a low carbohydrate diet reversed high blood pressure. Let's not argue the whole sodium thing again. This may explain our average 1.6 millimeters of mercury reduction in systolic blood pressure per 1 kilogram reduction in weight, an effect which is significantly larger than predicted by the average observed weight loss alone. These authors still maintain the belief that the sodium drives hypertension. They're physicians trained in the regular model, but at least they're thinking outside the box a bit. Their conclusion: adherence amongst people with type 2 diabetes or glucose intolerance to a low carbohydrate diet for an average of 2 years resulted in significant improvements in blood pressure, weight, and lipid parameters despite deprescribing 21% of the total drugs used for hypertension in these patients. Plus, the diet was well tolerated. It's easy. A heart failure study. So heart failure is a huge problem with high blood pressure. And one recommendation to patients with hypertension and heart failure are low protein diets. We're going to look at the complete opposite here. We're going to look at high protein versus standard protein diets in overweight and obese patients with heart failure, diabetes mellitus, findings of the PRO-HEART trial. It was a randomized control study. 76 overweight and obese patients aged about 60 years old, 72% were male, were randomized to high protein, which is they considered high protein 30% protein, 40% carbohydrate, 30% protein. I consider that low protein, but okay. Standard protein diet, 15%, very low, very low. Never do that. Reductions in weight and cardiometabolic risk were evaluated at 3 months. Both diets were equally effective in reducing weight and waist circumference, but the high protein diet decreased to a greater extent glycosylated hemoglobin levels. Interesting, 0.7%. Cholesterol, 16.8 versus 0.9. And triglycerides, 25.7 versus 5.7 when compared with a standard protein diet. The high protein diet also significantly improved both systolic and diastolic blood pressure than the standard protein diet. Conclusions: both energy restricted diets reduced weight and visceral fat. However, the high protein diet resulted in greater reductions in cardiometabolic risks relative to the standard protein diet. These results suggest that a high protein diet may be more effective in reducing cardiometabolic risk in this population. Very cool stuff they're doing. I love studies that look at the complete opposite of the guidelines and say, you know what, let's try this. I'd like to see more of these studies. Conclusions: essential hypertension affects a large proportion of the US and world population. It causes damage to pretty much every organ system and leads to heart failure and kidney failure. Evidence-based pharmaceutical blood pressure treatment based on the patient's ethnicity and comorbidity states provide the safest and most efficacious practice. The old theory of general low-salt diet recommendations to treat high blood pressure is now being shown as harmful, useless, and increases death. New understanding of hypertension explains that it is driven by inflammation, so treating underlying causes of inflammation is more likely to result in blood pressure targets being achieved. Low carb, higher fat, and higher protein diets are recently being recognized as not only helpful in reducing inflammation, but also in improving blood pressure, advanced lipid panels, and even heart failure. Very cool stuff. I'm glad to be able to implement these new modalities to help rapidly improve patients. As you can see in my one case study, this patient had a tremendous response to nose to tail eating, low carbohydrate diet. I think it's an effective tool. There's essentially no risk. If you look at the risk of the pharmacology part of this lecture, there's risks to every known pharmaceutical drug. The risks to eating nose to tail, eating higher protein, is essentially none. I would say the only risk would be in someone with advanced renal disease. That would be the only contraindication I would see and potential risk. So there you have it. Hope you enjoyed this lecture. See you next time.